Good morning and welcome to this important and timely policy event titled Solutions to Massachusetts Healthcare Workforce Challenges. I'm George Donnelly, the president of the State House News Service and Master List. The State House News Service provides round-the-clock, granular, nonpartisan, emphasis on nonpartisan, intelligence and news emanating from Beacon Hill. Master List is a free newsletter that curates top policy and political news and goes out every morning to 30,000 subscribers. Through our partnership with State Affairs, which owns 14 state government publications across the country, we now offer sophisticated legislative tools bundled with our content, including bill tracking for people who closely follow the action on Beacon Hill. We host several policy events every year, including one last year on Massachusetts competitiveness. Today we're here to talk about a vital subset of our economy, healthcare, and the workforce that makes it world-class. That workforce is under severe strain, particularly primary care providers, burnout, compensation gaps, bureaucratic burdens, violence in the workplace, and the need to grow the pipeline of the next generation of providers. We have a great program this morning to delve into these issues. We're honored to have Senator Cindy Friedman, Senate Chair of the Joint Committee on Healthcare Financing, and her counterpart in the House, Representative John Lawn, House Chair of the Joint Committee on Healthcare Financing. They're here to discuss legislative action directed towards the healthcare workforce. Before their panel, we have two segments. First, we'll hear from David Seltz, the Executive Director of the Massachusetts Health Policy Commission, whose agency has done some important analysis of the healthcare workforce. He'll be followed by a panel of experts in the field, both providers and administrators, including Steve Walsh of the Massachusetts Health and Hospital Association. We wouldn't be here without our event partner, Johnson & Johnson. Our thanks to the team at J&J. Now it's my pleasure to welcome to the podium Chris Lepore, Vice President, U.S. Advocacy and State Affairs, Johnson & Johnson. Chris, come on up.
Good morning. Good morning. Thank you, George, and thank you, Master List, for bringing us all together today. And thank you, Chair Friedman, Chair Lawn, for taking the time to join us today. I'm Chris Lepore, Vice President of U.S. Advocacy and State Affairs at Johnson & Johnson. I want to take a moment to recognize my colleague, Caitlin Berezin, who leads our government affairs endeavors here in the state of Massachusetts and does a fantastic job for us. At Johnson & Johnson, we believe health is everything. And for nearly 140 years, we have been working very hard to change the trajectory of health for humanity, bringing new innovative medicines and medical technologies to patients to help them live happier, healthier, and longer lives. And in fact, while our corporate headquarters is just down the road in New Brunswick, we have a significant presence right here in Massachusetts and have invested for many years in this state. In fact, if any of you have, or a family member has had a hip replacement, a knee replacement, or any spine implants, there's a good chance that any of those devices were manufactured right here in Massachusetts by Johnson & Johnson. And J&J is proud to be a part of the Massachusetts life sciences industry ecosystem, which contributes more than $35 billion every year to the state's economy. At J&J, we have more than 5,000 employees here in the Commonwealth across 9 sites with more than 1 million square feet of manufacturing, R&D, distribution, training, and office space. Our global headquarters for our sports medicine and spine division is based just down the road in Raynham, Mass, and houses our R&D teams with specialties like knees, shoulders, and robotics. We also have over 100,000 square feet of manufacturing space in Raynham that produces more than 1 million orthopedic implants and instruments annually for joint reconstruction. And healthcare professionals from around the world come to Massachusetts to visit our J&J Institute, where they learn cutting-edge medical technologies and learn how to improve patient outcomes. And Massachusetts is also home to our heart recovery business, where we develop and manufacture life-saving cardiovascular medical technologies to improve patient outcomes and patient care. We manufacture devices and have that business on locations in the North Shore. And then finally, our innovation center across the bridge in Cambridge. We collaborate with other innovators in the life sciences ecosystem to find the next generation of treatments and cures. And at the center of that are our people at J&J. They work at the complex intersection of biology and technology, developing the next generation of smarter, less invasive, and more personalized treatments for patients, from advanced mapping and navigation to robotic-assisted solutions. We're developing and delivering care to the hardest parts of the human body, the hardest parts to reach in the human body. But we can't obviously do that alone at Johnson & Johnson. We have a tremendous partnership with healthcare professionals. And critical to the healthcare profession are nurses and frontline healthcare workers. And for more than 125 years, Johnson & Johnson has been committed to empowering and elevating the nursing profession. And as we know, they are no doubt the backbone of the healthcare delivery system. Our objective is to attract and strengthen the innovation and the thriving community that the health nursing workforce delivers and empower them to advance access to quality care. And we do this through a variety of different programs and strategies at J&J, including a platform that we call J&J Care Community that champions nurses and the community healthcare workers to advance access to quality care. And we're proud the impact that the Care Community program has had, reaching 2.3 million healthcare workers globally through the first 3 years of the program. And our Nursing Workforce Solution program, which includes nurses at 10 hospitals across the Commonwealth, from Cape Cod to the Berkshires. That program aims to address things like professional burnout and to improve nurse retention, job satisfaction, and ultimately help deliver better patient outcomes. And my colleague, Isha Williams, is going to join us later this morning on a panel to talk more about how J&J is supporting healthcare workers. But now I'd like to take a moment to introduce our keynote speaker this morning. He knows quite a bit about the state's healthcare workforce. David Seltz is the first executive director of the Massachusetts Health Policy Commission. The commission is an independent state agency that is working in the public interest to improve the affordability of health care for all residents in the Commonwealth. The HPC's aim is better health and better care for all residents across Massachusetts, something that I'm certain all of us can agree with in this room. So please help me welcome David Seltz.
Good morning. First of all, thank you, George. Thank you, State House News Service. Thank you, Masterlist, for inviting me to give this keynote address and for hosting this wonderful event. As you said, a very important and timely event. Also want to thank Chris for that very short and sweet introduction. I like a short and sweet introduction. And for Johnson & Johnson for hosting and helping to fund this event. Shout out again to Caitlin Berezin, and thank you for that. I also want to acknowledge again Chair Friedman and Chair Lawn. Thank you for your partnership in the legislature. Yeah, clap. Woo. And I want to acknowledge the leadership of Steve Walsh at the Mass Hospital Association. We're really excited to have your expertise in hospitals to help serve on the HPC board. So thank you for that. And I have another HPC board member here too, Jamie Wilmoth from SEIU 1199. So thank you for being here. I think, George, as you said, this is an important and timely discussion, and I think that's really reflected by how many people are in this room. This is a packed room at 9 a.m. on a Monday, and I think we're all here because the health of our communities and our neighbors, the well-being of our clinicians, and the resiliency of our healthcare system is tied to the strength of our healthcare workforce. The workforce is the heart of our world-class healthcare system here in Massachusetts. And this workforce is in need of support. So I'm here to offer some opening remarks today and hopefully frame the robust discussions that we'll be having this morning with two great panels representing healthcare industry leaders and the chairs of joint healthcare financing, who will weigh in on some of the pressing challenges facing our healthcare workforce in the state today. But what I really hope is that in addition to identifying some of those challenges and some of the root causes to those challenges, that we can also focus on solutions and the critical need for action by all healthcare market participants, government, and policymakers, and that when we walk out of here today, that we're energized and committed to taking that action. I think understanding trends in the healthcare workforce has become a much more significant area of focus for the Health Policy Commission in recent years, especially since the pandemic. For the HPC and the state to understand and improve the performance of our healthcare system, we really need to understand the health and changing landscape of the workforce. And I know that seems obvious, but the pandemic and the years since have demonstrated very clearly that workforce dynamics can have profound impacts on care delivery patterns, health outcomes, and ultimately healthcare costs. During times of workforce shortages, patients can end up with delayed access to care, exacerbated health conditions, and with avoidable ED or hospital use. Shortages can also have implications for health system financial stability. One example is the use of temporary labor costs during the pandemic, which exploded as hospitals were desperately searching for temporary workers, primarily nurses, and had to pay these traveler agencies. These costs strained hospital finances at a time when labor costs were growing faster than revenues. So we have a lot of topics to discuss today, and where do we begin? So at the Health Policy Commission, we've issued 2 reports in the last 2 years, and we specifically looked at direct care workers, registered nurses, behavioral health care workers, and primary care providers. So I'm going to touch on each one of those. Not because there aren't other parts of the healthcare workforce that are really important and worth discussing, but that's just where I have a lot of good data, and I like data. And so let's start with some of the data. So let's start with some baseline numbers with regard to healthcare employment in recent years here in Massachusetts. So I asked the team to run an analysis comparing average monthly employment in Q1 of 2019 to Q1 of 2025. So basically before the pandemic to the most recent quarter of data that we have, 2025. In Massachusetts compared to the United States and broken down by different healthcare sectors. And some of the results were quite staggering. So the first headline is that employment growth in Massachusetts has lagged far behind the United States since before the pandemic in some critical healthcare sectors. Specifically, in psychiatric and substance use disorder hospitals, we have had 4.2% employment growth in Massachusetts from 2019 to 2025. In the United States, that's been 14.2% employment growth, a 10 percentage point difference. In outpatient care, in Massachusetts, 2% employment growth, 2019 to 2025. In the United States, 15.4% employment growth. And it's especially staggering when we look at some of the post-acute care settings. So nursing care facilities, workforce. In Massachusetts, 2019 to 2025, 16.4% lower employment in Massachusetts. In the United States, it's also lower, but a lower amount, 11.2% drop. So we are 16.2% lower than where we were in 2019. And in home health, another post-acute care setting, 5.2% lower today than we were in 2019. And that's a big difference from the United States, where in the United States, it's 13.9% higher. So the United States, they've grown in home health employment, and we're still lower than we were in 2019. These divergent employment trends between Massachusetts and the United States, especially in these post-acute care settings, nursing facilities and home health, has concerning implications. One, staffing shortages in these areas can have upstream impacts on hospitals, as we know that patients are staying longer in the hospitals, especially those who need to be discharged to a skilled nursing facility or home health. And patients waiting longer in a hospital, longer than needed, is not ideal patient care, first and foremost, but it also strains hospital staff and resources and contributes to patient flow bottlenecks. Patients waiting to be discharged are also taking up a bed for someone in the ED who may need that bed, which contributes to ED boarding. That's also a strain on hospital staff and resources, and not ideal patient care either. And there are also increasing numbers of patients who are waiting to be discharged with very long stays in hospitals. We're talking months, not necessarily for clinical reasons, but an inability to find placement in the next appropriate setting. This is clearly an example of the interconnectedness of our healthcare system and why strained workforces in some areas can have far-reaching ripple effects. So what do we know about the dynamics contributing to the shortages in these areas? When we looked in this a year ago, first it's important to understand the profile of the direct care workforce in Massachusetts. About 90% are women, 60% are BIPOC, and about half are immigrants. The median annual income is $37,000. Stakeholder reports and literature indicate to us that low wages without clear opportunities for advancement contribute to recruitment and retention problems. Solutions may include upskilling on the job or tuition assistance for additional training that may help direct care workers stay in these jobs. But with limited state resources in the near term and current federal policies and, let's say, federal attitudes on immigration, this is clearly a challenging outlook. All right, I want to move on and say a few words about nurses. Our nursing workforce challenges do not appear to stem from a lack of nurses. Massachusetts has a higher number of nurses per capita than the United States, and we've seen a 12% growth in the number of registered nurses from 2018 to 2024. In another positive trend, we've seen hospital reliance on that temporary labor, especially temporary nursing labor, continue to decline. In the latest SHIA financial report on hospital finances for fiscal year 2024, there was a $500 million decline in temporary RN labor costs from the year before and was about $500 million in that year. But we also know that there continue to be challenges in this workforce as many nurses struggle with burnout, administrative burden, and increasingly complex patient needs. The Massachusetts Nurses Association annual survey for 2025 found that about 36% of nurses said that they plan to leave the profession earlier than expected, and 1 in 5 said they plan to leave nursing entirely in the next 2 years. And among those who said that they were leaving, their top reason was burnout. And the M&A survey also highlighted a completely unacceptable and abhorrent fact that nurses are too often subject to physical and verbal violence and abuse in a healthcare setting. 70% of nurses reported that they had experienced at least one instance of violence or abuse in the last 2 years on the job. Recognizing that action is needed, my understanding is that MHA, MNA, and SEIU 1199 are all advocating for the first time for the same comprehensive legislation to address workplace violence in the healthcare settings. And I think it'll be really interesting to track that effort. Finally, on the issue of workplace conditions and burnout, I wanted to call out one new initiative that I came across aimed at workplace culture and nurse retention and patient outcomes. So this summer, an initial cohort of about 10 hospitals launched what's called a statewide Healthy Work Environment Academy. And they're going to be working with the American Association of Critical Care Nurses on an 18-month improvement program. It's a partnership with MHA. And they're going to be improving nursing engagement and reducing nursing turnover is kind of their challenges that they're going to be focusing on. And I wanted to shout out Johnson & Johnson because they're helping to fund that particular project. All right, behavioral health. I mentioned earlier that we lagged the US by about 10 percentage points for employment gains since 2019 in psychiatric and substance use disorder hospital settings. And similar to that dynamic of appropriate post-acute care, lack of appropriate post-acute care may delay a hospital discharge. Lack of access to psychiatric inpatient care can result in ED boarding, a persistent and vexing challenge in our healthcare system. So one quick stat, among children who are ultimately admitted to a psychiatric inpatient bed in an acute care hospital, nearly 50% of them were in the ED for more than 24 hours prior to that admission. So these dynamics are interlinked. There's been a lot of work by the state and by market participants in hospitals to try to address ED boarding, especially behavioral health ED boarding, and we're working on things like community behavioral health centers to try to reverse these trends. The latest data that I've seen is that it doesn't appear to be getting worse, but when 50% of mental health ED visits result in ED boarding, we've still got a long way to go on this particular issue. And I also did want to shout out State House News Service and Masterless because they've been writing and reporting on behavioral health boarding and ED boarding a lot. We're coming out with a new report from the HPC on this topic soon, so hopefully we'll have some new data and some new ideas on this. But of course, behavioral health providers work in a variety of different settings, inpatient, outpatient, clinic, integrated into primary care, and span a wide variety of different roles, social workers, counsel workers, psychiatrists, therapists. And we know, and it's been well documented, that there are significant patient access issues and challenges to needed and appropriate behavioral health care. There's a really good report that just came out of the Blue Cross Blue Shield Foundation on the behavioral health workforce, and it summarized the challenge in this way. I'm just going to quote it directly. An important cause of the behavioral health access crisis is workforce shortages. In other words, we do not have enough practicing mental health and substance use clinicians to meet the need for services. The impact of these workforce shortages, while resulting in unmet needs across residents in the states, are particularly concerning for people of color, people with primary language other than English, and LGBTQI plus youth. The Foundation's work is complementary to work that we have going on at the HPC through our recently established Behavioral Health Workforce Center. We were thrilled to partner with the Executive Office of Health and Human Services to set up this new center within the HPC to serve as the Commonwealth's primary hub for research on the behavioral health workforce. We're going to be having many reports coming out of that center in the coming years. Which brings me to the last area that I wanted to talk about, which is primary care. So we've seen significant workforce challenges in primary care and in turn impacts on Massachusetts residents. Earlier this year, we issued a report called Dire Diagnosis, the Declining Health of Primary Care in Massachusetts. And the report highlighted, I think, a number of challenges that are pretty well known to this audience. And we decided to focus on primary care because primary care is so foundational to a well-performing healthcare system. We know that access to primary care improves health outcomes, reduces disparities, and ultimately can help reduce and avoid unnecessary ED and hospital use. Yet despite all of this evidence, we also know that the investment and the spend that we put into primary care is declining. And like behavioral health care, represents a shrinking portion of the healthcare dollar. Here in Massachusetts, we spend about 7 cents of every healthcare dollar on primary care, and that number is going down. The downstream effects of this dynamic, combined with ever-increasing administrative tasks on the primary care workforce, are profound. As these providers are being asked to do more and more with less and less resources, less support, and with less time with patients. So one study found that providing evidence-based primary care without that adequate care team requires about 27 hours of work per day. Another study says for every 1 hour of clinical time, there's 2 hours of administrative tasks and documentation time. With increasing administrative tasks and without that support, it's no wonder that many of these providers are experiencing that burnout, thinking of leaving the field altogether or going into concierge practices. And these trends are further exacerbated if you happen to work in a community health center, which are even less able to compete on wages. And this can create this cycle of turnover, overwork for the remaining staff, burnout, and then more turnover. So without systematic reforms to address these issues, we're going to continue to face issues of clinicians leaving these fields or not going into these fields in the first place, worsening health outcomes of people avoiding or not having the access to the care they need. A CHIA survey found about 40% of residents say that they don't have access to the care that they need, with the most cited reason being an inability to get an appointment to a doctor's office. And that same survey found that when people said that they went to an ED for a non-emergency condition, 2/3 of them said that they went to the ED because they couldn't get a doctor's office and doctor's visit. All of this adds up to higher cost of care for everybody. And finally, we know that this also contributes to widening disparities of care and access and health outcomes. So while the challenges facing our healthcare workforce are profound, we know that policy interventions can help. And I'm interested to hear what the great panelists are going to recommend for policy strategies and solutions. But I'm going to throw out a few ideas for them to react to. One, reducing administrative burden and burnout. Let's redesign our program requirements in quality measurement, billing and coding, and yes, prior authorization to minimize administrative burden for clinicians. Let's invest in care teams, such as care management staff, medical assistants, social workers, and community health workers. Community health workers are amazing, and they can be so integral in addressing health equity because they're trusted members of the communities in which they work. We have to continue to strengthen that provider pipeline, reducing barriers to funding programs such as loan repayment or even better, upfront financial assistance. Improving our licensure processes, especially for behavioral health care. This includes reducing financial burdens, increasing access to information about these processes, expanding mentorship. We need to continue to innovate on new care models that can help relieve capacity constraints by offering care outside of the traditional settings, like hospital at home, mobile integrated health. And technology can help play a role in helping to support these new models. And we've got to increase spending on the things that provide value, things like primary care and behavioral health care. One of those ideas is setting a primary care spending target. This is a goal of the Primary Care Task Force for increasing that proportion of the healthcare dollar that's going to primary care and have a necessary rebalancing of our healthcare system to value. We're really lucky to live in a state like Massachusetts that has always been a national leader in public health policy, and has an unwavering commitment to improving care, improving access, and improving affordability for its residents. And this is true for our state's efforts in the workforce too. Healthcare legislation that was enacted just earlier this year brings us closer to that stronger workforce. Historic healthcare market oversight enacted earlier this year established a new office dedicated to state health planning in the Health Policy Commission, the Office of Healthcare Resource and Planning, or what we're calling OHARP. Their work to promote the alignment of healthcare resources with population needs will focus on also assessing workforce shortages and the necessary future alignment of the workforce with patient needs. This is going to be especially critical as Massachusetts is an aging state. Another key part of this legislation was the establishment of the Primary Care Task Force. I'm honored to co-chair that task force with the Secretary of Health and Human Services and to work together with task force members like Chair Lawn and Chair Friedman. Finally, there was transformative legislation that was passed about a year ago right now on maternal health care in Massachusetts that made huge strides in expanding the maternal health care workforce. This included licensure of certified nurse midwives and coverage for services by both certified nurse midwives and doulas through MassHealth. So we have a track record of taking this on, and we just have to keep at it. There's a new opportunity with this Rural Health Transformation Fund that was part of the federal legislation. Massachusetts could receive up to $1 billion in the next 5 years in federal funding to support rural health and the rural health workforce. I suspect many of you maybe have submitted ideas to EOHHS to help support the state's application, and I think we'll have a very strong application. So for those of you who know me personally, I am nothing if not stubbornly optimistic about the future of our healthcare system, a position I know that can seem increasingly challenging in light of recent federal policy changes and the persistent and systemic challenges we face in affordability and access and inequity. But I'm heartened to see everyone in this room today demonstrating attention to this issue and a willingness to move forward and to find a path together. We need to find ways to collaborate, to find ways to compromise, and find ways to work towards these shared goals together and safeguard the values that make Massachusetts, Massachusetts. We hope to continue this conversation with many of you past today at our cost trends hearings on November 12th. So thank you all for this opportunity to share some thoughts and to kick off this day, and I look forward to the panels. Thank you so much.
David, thank you so much. Appreciate it. David, thank you so much. Highly substantive, highly challenging, and somewhat optimistic. Now it's time for our industry panel. Would the panelists please, I would say, take the stage, but come to the table. We have Isha Williams, Global Lead, Healthcare Workforce Strategy and Programs, Global Health Equity, Johnson & Johnson. Dr. Elisa Choi, representing the Mass Medical Society. Steve Walsh, President and CEO of the Massachusetts Health and Hospital Association. And I just leave the middle for our moderator. Hiyam Nadel, Center for Innovations in Care Delivery at Mass General Hospital. And our moderator is Gin Dumsius, the editor of Master List. Thank you all for being here. Gin, it's your show. Take it away.
Thank you, everybody, for being here. Can you all hear me? No.
I think you got to turn it on. Click it up. That button. Press that button up. Now you should go. Be good.
All right. I went into journalism because I was told there'd be no public speaking, but here I am. So thank you all for being here. I really appreciate it. We don't have a lot of time, so I do want to get right into it with Isha, and I wanted to ask, we know J&J, pharma, medical tech company. Why is it involved in supporting nurses, and what are the programs in your mind that are the most effective, most impactful?
Thank you, and thank you for the opportunity to be here today. I hope everyone can hear me okay? Yep. Excuse me. So as was mentioned, for over 125 years, Johnson & Johnson has had the privilege to advocate for, to elevate, and to help empower the nursing workforce, because we believe that nurses are the backbone of healthcare. And more than that, we also believe that nurses are uniquely positioned to drive healthcare forward. They have invaluable insights. They have the hands-on experience. They have innovative ideas for the solutions that we need. And it's especially critical at this time that we support nurses as we look at a global shortage of 4.5 million nurses by 2030. And that's why we launched J&J Care Community, which is our global social impact platform that champions nurses and community health workers to advance access to quality care. As it relates to nurses specifically, our goal there is very clear: to help lift up nurses as a thriving, empowered workforce. And we do that in 3 specific ways. We champion nurses by helping to elevate their worth, their value, their skill set, their leadership through media and through events, so that we can help to reinstill that sense of nursing pride. We also equip nurses through a series of leadership and innovation programs that help translate the ideas that nurses have into solutions that they can put forward into the health systems that can benefit all of us, because we believe they have the transformative solutions that we need. Excuse me. And third, we help connect nurses to resources. So we have our hub, nursing.jnj.com, which is a one-stop shop for information on nursing scholarships, grants, well-being resources to help nurses to have everything that they need to deliver the quality care that we need. And already in 2025, through these various efforts to champion, to equip, to connect nurses, we've been able to impact 650,000 nurses and health workers with our support, with an ambitious goal that we will meet to affect 1 million by the end of the year. So we believe that nurses are absolutely the anchor, and it's our privilege to support them, including several programs that we support here in Massachusetts.
All right, thank you very much. It's also, I should add, my mother was a nurse in Lithuania before coming over, so I'm very familiar with kind of the workload, and certainly there was a period, she worked at John Hancock for the rest of her life, but for about 10 years she worked weekends at a nursing home and kind of putting that training to work. I often wonder if she'd been able to make the jump to, nursing was always her passion, but she had to go into financial services. But I always got to see it up close, something she was always very passionate about.
Fabulous.
So, Hiyam, I want to thank you for being on the panel. I want to ask, you have a very unique job at Mass General. Tell us a little bit about that job and how it impacts the staff in the hospital.
You bet. Thank you for having me here. I first want to thank Johnson & Johnson because I was an inaugural Johnson & Johnson Innovation Fellow, and it gave me instant credibility as I tried to build this center at the hospital. And David, I just want you to know thank you for raising all those conditions because I live them every day. So the center really is all about empowering the front lines, and the way we do that is to ask them about their pain points and their ideas for solution. And then they come to my center for incubation, acceleration, implementation. And what we're finding is that it's bringing joy back to the bedside. Because if they have agency over their workday, or they visualize what the problems are and able to implement solutions, it's been great for them. It also, for our leadership, has really sort of closed the gap. You know, as a leader, I think the problems are these, but hearing directly from the front lines keeps them more engaged and closing that gap for them. And I think that's what we do. So we have a lot of good ideas, and I always say just ask. That is the first step.
All right. I'm going to turn and ask Steve about, you talk to a lot of people in your job. Tell me a little bit about what you're hearing and what you're hearing about the biggest workforce problems overall. Where are they feeling it the most?
Yeah, thanks, and thanks to the State House News and to an extraordinary panel, and special thanks to David, who really highlighted the important issues that I know our two chairs have a handle on them, and it's really good to see my former Chair Senator Moore here, and we were talking about these things 13 years ago, and in some areas it feels like we've made some progress, in other areas we've gone backwards, but David hit all the right areas, but it's important to kind of understand the why. Like, we think about administrative simplification, and everybody uses that all the time. Well, what does it mean, right? We send 9 billion faxes in healthcare a year. Faxes. I don't know how many people in this room that don't work in a hospital still have a fax machine, but if you think about the cadence of healthcare, and then you're waiting for the fax to come through so that you can give a patient something that they need. It's unbelievable. I mean, and then we fight this idea that we're not Blockbuster Video. And you think about burnout, which David talked about. Well, you have more people that are losing their health insurance. When they lose in health insurance, where do they go? They go to the emergency room. By law, when they show up at the emergency department, they have to be treated. Now they're waiting, and they're in that emergency room sometimes for 6, 8, 10 hours, and if anyone here has been there in the last 6 months, it's a really difficult place to be. I'm a person that represents hospitals, and I say the worst place to be if you're sick is a hospital. If you got to the emergency department, we didn't do our job in primary care and appointments and anything else. We have to be managing this upstream. So now you have a workforce that's trying to find the needle in a haystack, the really sick person in that ED to care for first. And who do they choose? How do they measure that acuity? And then you think about workplace violence, which David mentioned. You tack all those things on, and then every 36 minutes in a Massachusetts hospital, one of our workers is assaulted. So what is that, 3 since we've arrived here this morning? 3. And we're not talking about it. Now, Chair Lons and Friedman have done a really incredible job of bringing us together, as David said, our partners in organized labor from M&A and SEIU, and we'll get there this year. But why does it take so long to protect the people that care for the people that we care about? It's absolutely beyond me and unacceptable. And so these things are perfectly explainable. They really are when you dig down into what's happening. The real frustration for really smart people in this room is that they're also all fixable. And we ought to figure out how to do some more things together. Everybody uses the word collaboration. And I'll say the one collaborator that I know we've worked with in the room this morning is J&J. It's real. I mean, the praise for them this morning is real. What they're doing in our Healthy Work initiative to make sure that the workforce is empowered to make decisions about how their day goes is really critical and really important. That's real collaboration. Everybody else just uses the word.
Thank you. I do want to circle back on workplace violence because that is a striking number. But I do want to quickly ask Dr. Choi, in your mind, what is the biggest challenge facing frontline workers, especially nurses?
Well, thank you. First off, I'm thrilled to be here, and it's really heartening. So to give everyone background, I'm a primary care infectious disease HIV physician in practice, and I'll be going back to my practice right after this morning. So seeing so many people across so many diverse sectors of the healthcare industry putting our heads together to try to solve the physician, healthcare, clinician, nurses, workforce challenges is actually really inspiring and encouraging. So to answer the question, there's so many answers to give. What can I start with? So first off, I wanted to call out and thank Executive Director Seltz for being so pointed and articulate and data-driven about the workforce burden and why we're struggling so much. I'll pull just from my day-to-day, and Steve Walsh alluded to the faxes. That's just one of thousands of sort of minor cuts that we suffer over the course of the day that can then spill into a complete burnout and crisis of compassion fatigue and all of these other issues that affect the workforce. Definite administrative burden. Just to give you a snapshot of what my day is like, I see patients for however many number of days, but that's only half the job. Then there's messages, asynchronous messages from patients. There's faxes to try to retrieve, if we can retrieve them. There's portal messages. There's all sorts of prescriptions. So what has been one of the biggest impacts on our job doability, frankly, is the fact that what we really strive to do, what we went into medical school for, what we went into clinical care for, is to take care of patients and have that face-to-face relationship develop and to practice medicine. But then it's everything else that's beyond the practice of medicine that has been incredibly crushing. So let me just also cite a few statistics to illustrate how deep the problem is. We're in Massachusetts, medical mecca of the country, if not the world. We have the most number of physicians per capita in the US, but we are the 5th lowest in the US in physicians who go into primary care. So I see a lot of nodding heads, so I'm sure when you try to get your own primary care physician, you're really hoping your primary care physician doesn't retire. So when they do, then you have a wait period of however many months. And that's all going back to root cause of all of the burdens of what the day-to-day pressures are like for clinicians and physicians. And I'm so privileged to work with some outstanding nurses, and Ms. Isha Williams talked about how important the nursing workforce is. Medical care these days is an absolutely team sport. We can't do it without our nurses. And if we don't solve the crisis of what makes the job undoable, not just for physicians, but also for our nurses and for, frankly, all of our clinical team members, we won't really get to a condition, our sort of next state where we actually have enough people in clinical care. So I would say in summary, the biggest administrative burden, it's multi-pronged. It has to do with all of the non-clinical, non-face-to-face administrative tasks that are not actually clinical care, but that are related to the billing or the reimbursement or anything that is not actually taking care of patients. And that right now has become this mountain of crushing burden that is really taking away, for many physicians, the joy of why we went into practice. And so I'm hoping that with further conversations today, we'll at least start to chip away at some of those issues and come up with solutions.
Thank you. I do want to open that up to the rest of the panel, actually. What, in terms of bureaucracy, and is it right? Is that a good term for?
Yeah, absolutely. Bureaucracy is a great word for it.
So to what degree is bureaucracy detracting from care and contributing to burnout? Does anybody else want to weigh in on that?
You know, since I started to practice, most of the time when you're seeing a patient, you're really just focused on their medical condition, et cetera, and building a relationship with the patient so you're getting to know them. But then you have all these things that have to be done, and in isolation, they're all important, but the compilation of all of that just really puts you down. So, and so that's why team-based care is so important, but we can't afford to hire the team, or they're not available to hire. There isn't enough. And so those are the things that really weigh us down. And in a weird way, during COVID, with as frightening and as sad as it was when losing patients, we all had a North Star. We just took care of patients. So we documented what was necessary. And then, you know, we just took care of all the barriers, and all those things just went away. And I wonder if that's where we need to go back and reevaluate.
I appreciate, please excuse me, my voice today. I appreciate what nurse leader Hiyam said about just ask, because so many times some of the solutions to these challenges, the nurses who are delivering care, who see the systems, who see the tools every day, they have many of the solutions that we need, but often we talk about the nursing problem. We try to find solutions without giving them a seat at the table. So some of the programs that have been mentioned, like the Johnson & Johnson Nurse Workforce Solutions Program, we're currently working with 10 hospitals in Massachusetts. This is a year-long program, a team-based program, that puts together nurses to become clinical leaders and help solve solutions of staffing, of well-being, of even impacts to cost in the bottom line, which is of high consequence to health systems. And we're very happy to have true hospitals in Massachusetts as well as hospitals across the country being a part of that. Another example of empowering nurses is through a Johnson & Johnson program, our Nurse Innovation Fellowship that Hiyam mentioned she was a part of, but Leahy Hospital in Massachusetts is a part of that. That's another year-long team-based approach, bringing together nurse leaders and their core teams to find solutions to some of these nurse well-being tools. So the solutions are not easy, but what we always like to emphasize, including through the excellence in Massachusetts, is that by bringing these nurse leaders to the table, we have a higher chance to actually solve the issues that they're facing. And we hope that as excellence and solutions and great ideas are found in Massachusetts, we have a true commitment to help elevate that and promote that to other nurse leaders and health systems across the United States.
I think the reference to COVID is actually the right one. I mean, obviously it was a time nobody wants to think about, but when one statistic that I'm incredibly proud of is that we had the lowest percentage of avoidable loss of life in the country. And the reason was because we all work together. And we're really good at emergencies, right? It's in the DNA of healthcare workers. The door opens, somebody comes in, they fix them, they send them out. We're really bad at proactive thinking. So in the moment, we can do it, and we can do it really, really, really well. And what the state did at the time was they reduced all of the administrative burdens. They basically removed all the barriers to be able to provide care in an efficient manner. We should look at that long term. This is like if you never once in your entire life cleaned out your closet. It would be pretty difficult. You'd be on an episode of Hoarders. We don't clean out our closet in healthcare. So the regulatory burdens that we had in 1950 are still there on top of the regulatory burdens that were passed last year and the ones that will be passed this year. And as good a job as HPC and CHIA have done to try to work with providers throughout the Commonwealth, we have this incredibly burdensome system that it absolutely impedes frontline workers' ability to deliver care to their patients and do it with enjoyment. They're supposed to love the job. It's a vocation. And to reconnect people to the mission of it will never happen if we don't reduce these burdens.
I do want to ask about faxes. Is there a requirement for faxes, or when you were talking about the...
There's a whole lot of legal stuff that other people can explain more than me about why we can't send certain things and HIPAA and other challenges, but they're fixable. Someone here can ask ChatGPT and know within the end of the moment that how we would be able to fix this.
Yeah, if I might just jump in on that question. So first, for the fax, I'm just speaking on my own experience and not on any representative position, but my understanding is that because of certain regulatory privacy reasons, fax is considered the most secure. And that, I think, bears some looking into. But back to the question of the administrative burden, the bureaucracy, I'll give a concrete example for what I face day to day. I might have a patient who has been very stable on a certain medication for months, even years, and then they have a plan change or a payer change, and then suddenly that medication is no longer quote unquote first tier or covered. And so then that generates a whole cascade of unbelievable amount of burdensome messages that has absolutely nothing to do with clinical care, because the patient is doing fine on that medication, but because of the current complex network of all of the different parties that have something to do with healthcare, including payers, and then the formularies, et cetera, we have a system that amount of time that we will spend dealing with that cascade of messages to essentially keep the patient on the same medication that they're doing well on could be time better spent with outreaching directly to our patient, adding on a clinical visit to see another patient who needs to be seen so that they don't end up in the ER. Instead, what we have is this kind of quagmire of bureaucratic administrative burden that takes away. And then I can't emphasize enough the workforce issue. We want to be able to wake up and go to work with joy that we really are doing something every day taking care of patients, rather than thinking about the complete list of 100 or so burdensome messages that have nothing to do with care.
I wanted to circle back on what Steve said about workplace violence. I first realized what an issue it was probably post-pandemic. I was sitting in a doctor's waiting room, and the signs were everywhere, and that was very striking to me. I didn't even realize that it was such a huge problem. And I wanted to put it to everybody, if you want to answer it. What do you think is driving that? And have you had your own experiences?
Well, I don't want to overspeak, but I personally have been very lucky that I have not faced a workplace violent incident. I can't imagine how terrifying that must be. And if we want to think about root causes, one that comes to mind is actually our complicated healthcare system. I work in the healthcare system. I deliver care, and I face frustration. Just getting an appointment will take me 20 phone calls sometimes. Can you imagine what it's like for someone who doesn't speak English as a first language, who has relatively less sophisticated understanding of medical literacy or the healthcare system? So patients are encountering increasing obstacles and their own burdens to getting care. That drives frustration. There's the fragmentation of care. Nurse leader Hiyam alluded to it, the lack of ability to build the relationship because of how complex the healthcare system is. And when that all comes to a head and someone is having, for example, acute pain that doesn't feel like it's getting resolved, no way it excuses any violence, but one could potentially empathize and understand with why someone who is seeking care and can't get it may feel like they have to resort to extreme measures.
Yeah, we have a society that is now pushed to vitriolic speech and actions on a very regular basis, unfortunately. I think we're still blessed here that our elected leaders can have debate without being disagreeable. But when you take that, what we're seeing nationally, and you put it into an environment that is so emotional, where one of you or a loved one is in your most vulnerable moment of your life, bad things can happen in that recipe. When you have capacity challenges, wait times, and I was there Christmas Eve with my dad, 10.5 hours. Now, he was 92, he was attacking nobody except the couch. But it creates a stressful situation. Now, on the other side of that, we don't excuse the behavior, and I'll say, why else does it happen? Because people can. And they don't attack TSA agents, they don't attack police officers for the most part, but we don't have laws in place that everybody understands when you walk into a healthcare environment, you are not going to touch a member of that workforce, or there's going to be significant penalty.
I just want to add that, I think through the Nurse Hack for Health and all the Johnson & Johnson programs, we're hearing this globally. So this isn't just a Massachusetts issue. But, again, I agree. I think that, right now we give our patients a sort of a contract, like don't misbehave, and things like that. But, it's just the general incivility is just really bringing us down. It shouldn't be tolerated.
So we're coming up on time, I believe. I did want to ask. We have policymakers in the room. There'll be 2 lawmakers on the next panel. I did want to ask. You've got an open mic here. What would you like them to be thinking about when it comes to supporting the workforce, and what should be top of mind in your view as they move ahead through the legislative session? Dr. Choi, you want to start?
Sure. At risk of asking for too much, first, I'm really grateful to Senator Friedman and Representative Lawn for their leadership. I will echo what our Mass Medical Society, which advocates for the physicians in our state, is really advocating strongly for, and it comes down to 3 main areas, one of which is working on improving and expanding the pathway to get into medicine. And that can boil down to a number of different sort of ways to do that, including legislation that enables entry into the workforce, loan forgiveness legislation that can help reduce the debt burden. It's upwards of $250,000 to make it through medical school right now, and then going into post-medical school training doesn't necessarily cover the costs, and that leaves physicians indebted for years. And so thinking about how can we help our promising students who are interested in taking care of patients go into the field, so introducing ways or expanding ways for pathways into medicine. Second prong to the big ask would be related to the practice of medicine itself. And there's a lot of burdens right now, so working on and partnering with industry and healthcare organizations to try and create legislation that will reduce some of the unnecessary administrative non-clinical burden. Executive Director Seltz pointed it out quite clearly. I see a patient for an hour. I know I have 2+ hours of work after that patient, and that is real. That is absolutely real. And how do you get 27 hours worth of work into a 24-hour day if you need to eat, sleep, and take care of other work things? So we need to work on the practice of medicine and making it job doable. And then the third prong, I know that the Mass Med Society is working really hard on, is related to practice sustainability. We don't often like to put too much focus on payment, but we need to. If we want enough physicians to be able to sustain their practices, to be able to keep taking care of patients, we do need to think about what can we do as legislators, as industry leaders, as healthcare organization leaders to ensure that reimbursement is commensurate with cost. Even some of our private practice physicians can't make enough back in just seeing their patients from reimbursement, which continues to decline, and they need to pay their own staff. We live in one of the most expensive states in the country, and the cost of living never goes down. It only goes up, but reimbursement sometimes goes down. So we have to reconcile that diverging kind of curve of increasing cost of living increasing rent, et cetera, with the fact that some years, even our reimbursement will not keep up with the rate of inflation. So those three areas, I would love to see a lot of progress. Pathways into medicine, the practice of medicine itself, and then practice sustainability and survivability. Thank you.
Steve, if you want to.
Thanks.
Former lawmaker.
Look, I think David Seltz outlined really well the policy concerns, and I think we should all share them in some degree. I don't have anything to add for Chairs Lon and Friedman. They're really extraordinary people that care deeply about their communities and their constituents. I am a former colleague, but I say that because it's true. Chair Lon has a mother, a nurse, a daughter, a nurse, 5 kids. Senator Friedman is one of the most compassionate people I've ever come across. So what I ask them to do is going to pair in comparison to what they see and learn on their own. I would just say that we should all just think like patients. That's when we get it right. Like if we just, every one of us here, forget who we work for a moment, and we wrote down the top 3 things that impacted us negatively as a patient, and we then added it all up and picked the top 2, do those. Because they're really, really the right things to do, and patients know what ails our system better than anyone else. And the one thing we all share in common is that at one point or another, we are all patients. And so think like a patient and we'll be just fine.
I would just add to that to also think about the healthcare professional and what they're going through and their challenges. We've mentioned the burnout, we've mentioned the violence. Johnson & Johnson has been proud to support the Dr. Lorna Breen Foundation, which advocates and has national legislation that we have supported for healthcare worker well-being and job satisfaction and mental health support. So as we're looking to enact legislation to support the actual delivery of care, let us not forget the healthcare workers and allowing them to be able to come forward freely with the mental health and other well-being support that they need to continue to serve us and to serve our communities.
All right, you get the last word.
Yes. So in my center, we just started asking patients, not just staff, what are your pain points or what are your ideas? And we're collaborating together to build out those solutions, because it's amazing what I think as a clinician is important to the patient and what the patient is telling us can be quite different. So thank you for bringing that up, Steve.
All right. Well, I think I want to thank all the panelists. I think we covered a lot of ground, short amount of time, and I'm looking forward to hearing what the lawmakers say in response. So thank you very much, everybody.
Thank you again. Thank you, everyone. That was an excellent panel. And it tees up our 2 co-chairs of the health care financing. Please come on up. Senator Cindy Friedman, who is the Senate Chair of the Joint Committee on Health Care Financing, and Representative John Lawn, the House Chair, Joint Committee on Health Care Financing. Yeah, I'll sit in between you. Yeah, if that's okay. Sure. You get along. Shouldn't the House be on the right, do you think?
Yes.
But maybe it's on the right to the crowd, so that's really what matters. Well, no pressure on you 2. You have been mentioned many times, and I'm sure you have a lot to talk about. But first of all, it's a real privilege to have you both here this morning. There is a lot to talk about. There's payment for primary care. There's the administrative burden. We went into a fair amount. There's the workforce pipeline, and there's the growth of violence in medical settings. But I thought we'd start with the administrative burden and the efforts that didn't quite get across the finish line last session, which I think are probably in play again this session, and that is, in part, that's prior authorization reform. Let's talk about that, where that's at, what stopped it from happening, and what are the prospects for getting that across the finish line this session? Why don't we start with you, Senator?
There's a lot invested in prior auth, and it's a hard thing to give up, right? It started out as something that was really useful, trying to mitigate some of the overuse of treatments and pharmaceuticals, and it's turned into something that's about really denying care and making people go through the hoops, the many, many hoops to get something to a patient that they need. And a lot of people have a lot of entities have a lot of vested interest in keeping it the way it is. I think we've worked hard over the last 6 or 7 years to try and address it, and now I think we're at a point where we've tried to work with people, we've tried to work with the different entities, and now it's just time, I believe, for the state to say stop. Why we have prior auth in primary care, not sure. Can we change it? Absolutely. Where there's a will, there's a way. So I believe that we really need to put our money where our mouth is and do things like stop prior auth in primary care, ensure that prior authorization is absolutely the same across all payers, because if it's evidence-based, it's evidence-based for Blue Cross Blue Shield, it's evidence-based for .32, it's evidence-based for Fallon. You can't have different standards if you're ensuring us all that, no, this is evidence-based and this is best practice. Well, if it's different, then what else is in there? And I think we have to very much rein in our PBMs, because I think they are absolutely part of this problem. It's not only an issue of treatment, but it's an issue, as the doctor pointed out, why, when you have a medication that works, should anyone in the entire universe have to change it because they changed insurers? Insurers aren't delivering care. Providers are delivering care. So can we get it across the finish line? I think if the healthcare community really stepped up and started screaming as loud as some of our other advocates, we may be able to do something. I know that the Rep. Lawn and I are completely on the same page with this. So,
Well, there's an argument against it. Representative, what is the argument against it? What stops it then? I know obviously there's vested interest to stop it from happening.
Well, I think like anything, it's a little bit more complicated because prior auth does serve a purpose, but I think, as the senator said, it's overused. I think we're also seeing now with AI coming into the marketplace of AI denying claims, and that's something that is a new issue for us to deal with, and we're going to have to address. But like the senator said, everyone in this room has experienced an issue and a frustration, whether them or a family member, with dealing with healthcare and prior authorization, where so much of our primary care doctors, especially, who are ordering tests and then have to go through this administrative burden, especially small practices, where a bigger system might be doing that together. It's putting an enormous stress on our primary care doctors, and I think as we see the burnout, that's something we really have to address. If you go to your primary care doctor and they send you for a test, it should not be this burdensome challenge that it is. And one issue that the doctor brought up about the medications and the different formularies, that step therapy law that we did should have addressed, and that it's not, is actually concerning, because that was part of the whole step therapy law that we passed, was that you could not send people back to a different drug on a different formulary. And so that shouldn't be happening, and that's something that the legislature had addressed 2 terms ago, was the step therapy bill. But I think we're committed to continue to work with stakeholders to find out where we can really limit our prior authorization, especially when we see 93% of prior auths at the end of the day going forward. I mean, that's really frustration. Those things shouldn't just happen, and they shouldn't be denied, and we should put that on our we shouldn't put that burden on our primary care doctors and their staff.
I was heartened and impressed to hear about the creation of the primary care task force. You're both on it. Talk a little bit about. Obviously, it must have a huge omnibus agenda with so many things going on there. But let's talk about what you hope to achieve there.
For me, I think it's twofold. It's one, how do you define primary care? And what does it mean to deliver primary care? I mean, primary care is becoming this huge bucket. We throw everything in it and say, oh, that's primary care. And that's not doable. So I think the first thing that I want to look for is how do you define it and what does it mean? And then the second piece of it is how do you shift healthcare dollars to primary care and ensure that those dollars are going and staying in primary care. I think one of the things that that's happening in the healthcare system is that more and more primary care practices are becoming parts of systems. Once you are part of a system, it's very hard to track where those dollars are going across that system. And I think that's the real challenge for us right now is how do we ensure when we say to our insurers, you have to shift your dollars from specialty care to primary care, we can track what those, those contracts are. But once it gets into the system, we lose sight of it. We can't see what's happening. And I have a very strong feeling, that dollars that are going into systems that we think are going to primary care are in fact not, or they're being clawed back. So I think for me, the two really big pieces of primary care are how do you define it and how do you track that we're moving dollars there?
Representative, on your end, what do you hope to achieve with that task force?
So I think I applaud the Senator for putting this together, because it really is we're at a crisis in primary care and we need solutions. It is a great broad group of stakeholders in the healthcare that are coming together to try to solve some of the issues in primary care. And as we said, also, we've got workforce challenges, we've got doctors who go to medical school who would love to be in primary care, but often go into a specialty. We've got to figure out how we can stop that and incentivize primary care doctors to stay in primary care. It is a calling, and people want to do it, but we have made it so difficult in this country to support our healthcare workers, for them to go to school and come out with an average of $250,000, $300,000 or more in student loans, when these people are going into a profession to help people. We've got it totally wrong, and we really need to rethink how we train and support our healthcare workers. And if we want people to stay in primary care, we've got to support them, and we've got to, take away all these obstacles that we were talking about with prior auth, and let those doctors stay with their patients, because that's what they want to do, instead of having to work with all these administrative burdens, worrying about also, what about their own situation? How about student loans that they're burdensome, the high cost of housing? They're regular people who are dealing with the same issues. And if we want more primary care doctors, we really need to step up and support, not just them, all of our healthcare workers, I believe. We've got to figure out a better way to fund them and support them from them entering into a pathway to medical school all the way to becoming a doctor or a nurse or mental health or behavioral health professional.
Well, that tees up a bill somewhat controversial. Why don't we jump into that? That you've introduced. You both, I think, have revenue-oriented goals, but yours is it comes from nonprofit institutions, right, or universities. So tell us about that bill, and I'd be curious what the pushback has been. It's kind of very innovative and different, and.
So I filed a bill last term and again this term, which is a bill that assesses private endowments 2%, 3% over a couple of years to set up a healthcare workforce stabilization which could also be another way to fund other parts of healthcare to stabilize our healthcare system. When I look at, and it's been proposed before, that people have proposed that we assess endowments, private endowments, that money would go to the general fund. People have brought that up before, that they feel it's unfair, that some of our endowments have gotten to the size they are, that are tax-free. But when we look around, we have to come up with solutions, right? We have to figure out how would we fund some of these things. And one of the things that stemmed it from was, I represent a part of Newton, which I see my colleague, our primary care physician, Greg Schwartz, who's there as well. And the Mount Ida campus, I had a study, which was the UMass Amherst campus had bought. It's pretty much a turnkey college that has been totally underutilized. That sits within 5 miles of all our major medical systems. And so why can't we work to expand this campus for a healthcare workforce training center? And I also think that we should be funding our healthcare workers through this endowment. So the money would go back to colleges who are training healthcare workers to pay their tuitions, with the incentive that they stay in Massachusetts and work in healthcare for 10 years. So I don't care what profession in healthcare you are, we will support you and we will fund your education as long as you stay in Massachusetts for a certain amount of years. After that, they're free to go, especially if we had doctors in primary care say, you stay in primary care for 10 years in Massachusetts, we'll forgive your loans, we'll pay your loans. I think that would, because I think it comes back to some of the growth David Seltz talked about, we're falling behind many parts of the country, but we have to go back to housing, right? Housing is a huge challenge in that, and we can't forget that. So all these doctors, all these healthcare professionals, whether in nursing, they need to be supported. We need to figure it out on our own. I think a lot of our issues are global issues too. I don't think it's just Massachusetts, I don't think it's this country. When you look around the world, they're facing these same challenges. And we are not going to look for immigration to figure this out right now. We need to figure it out on our own. And I think that we have an opportunity in Massachusetts to be innovative and supportive of our own residents. And I also say we should be going into our neighborhoods of color. And we should have culturally responsive care. We only do that if you have people of color working in this profession. And we saw that during the pandemic. There's plenty of smart people who need to be supported, not just financially, but supported to stay in these careers, because you can uplift the family if you give them a good job. We know that. And we should be just making it much easier for our healthcare people to get into this profession.
Thanks. Senator, you filed a bill, I think it's Senate 867. I think it focused somewhat on the whole payment issue, right? Is that, or tell us about the goal of that bill, which I think in part at least is trying to direct more funding towards primary care.
I think what you're talking about is the primary care bill, which looks at how do you fund, how can we fund primary care? And I think one of the things that has happened in the state, which is really interesting, is Mass Health has come up with a subcapitated primary care model that it's not perfect, because no model is perfect, but it's really interesting, and we've heard from a lot of providers that that they're pretty happy with it. That it's, and so one of the things that we're looking at is how do you extend that to the commercial space, so that it would require all commercial insurers to have a benefit plan that is exactly the same, because again, what we need to do is standardize across the board, across all of our payers, to take away some of the administrative burden of having to do everything differently based on the payer. But how would you provide a benefit plan that a doctor could the doctor could sign up for? That would be a subcapitated primary care model based on what we've done in Mass Health. Just to get the administrative burden out of it, to have standardization across the board, and to make it easier to provide the care. So that's something that we're looking very seriously at, because again, it comes down in a lot of ways to the payment model and how do you deliver care and how do you get paid for it within the primary care space.
Things are challenging, and they may get more challenging with Medicaid cutbacks, right? As Steve Walsh mentioned, some of the pressures that could come to bear, very likely will come to bear in hospital emergency rooms. How worried are you about these pending Medicaid cuts? Is there something on your end that can be done? Obviously, funding is one of them, but how much are you anticipating where that might go?
Well, I think the first, we'll see in January, the first phase of over 36,000 people who will lose health care coverage, who, as Steve Walsh said, will still at some point show up at one of our hospitals. And now our hospitals, as we know, from just a funding relief we did 2 weeks ago in the legislature for $234 million, just to support our community hospitals and our high payer mix of public payers who are really struggling already. So we're going to have some more challenges on top of that when these people show up for care who don't have insurance. I think this, what is it, OB3 we're calling it now, is being phased in over the next few years. Many of the real hits will be after the midterms, which is pretty scary. But these challenges that our hospitals and our community health centers are going to face with people showing up with no insurance is really going to put an enormous amount of stress on our hospitals. But the funding that we just did, which was very clear, we tried to say that does not solve any of our challenges. It just provided a lifeline as we try to figure out what our next steps will be. I think maybe with the shutdown there'll be some concessions, hopefully, in healthcare, but I don't think we can count on anything right now. So we're going to have some really difficult challenges to work with our healthcare stakeholders to keep things afloat while we figure this out.
Well, we're scared shitless. I mean, I don't quite know how else to say it, but this is, this is a direct attack on poor people. It's a direct attack on our value system, and the question is Massachusetts, what's Massachusetts going to do to rise to the occasion, right? I think that it is really important that we use this opportunity as an opportunity and not just as a crisis. I think it's time for us to look at how we deliver care and what changes we could make in that delivery of care so that more people get upfront care and less people have to go to the hospitals, because our hospitals, unless we decide that we're going to, let people die in the streets, honestly, they're going to take care of people who come to them. And that's their job, and that's what they signed up for. And so what we need to do is take some of the pressure off of them so that they can actually treat people who belong in a hospital, and we can move people to those places like our community health centers and our primary care physicians so that they can get the care they need when they need it and they don't end up in the hospital. We can make that choice. We can say we're going to use this as an opportunity, or we can just cut, do random cuts and die by 1,000 cuts. Or we can say this is a great time. What are the programs that work in Mass Health? What are the programs that aren't delivering? Let's shift our dollars to those. Should we have very complicated financial payment systems in Mass Health, not because of Mass Health, it's not Mass Health's fault, but it's because of all the things that they have to juggle. Are they right? Are we saving money? Does it provide quality care to the patients? But we have to take this opportunity and to make changes that we would need to make anyway. And our question for this state is, are you willing to make those changes? Are you willing to put that time in? Are you willing to make those hard decisions? We have been a leader in healthcare. It is true. We've done wonderful things. It's been 13 years since we've done a major change in our healthcare system. We are no longer the leaders that we think we are. There are states that are going way beyond us, and we can't sit on our laurels. And we did it in 2012 and 2006 because we had a will to do it, because we cared to do it. And that's what we need now. And without that, we're just going to be doing little things around the edges, or we're going to be cutting programs that people in this Commonwealth desperately depend on.
Workforce violence came up a few times. Steve Walsh was very pointed, I think, about some messaging, maybe, and the analogy to TSA, et cetera. Rep. Lon, I believe you have filed legislation around that. You want to get into that a little bit?
Sure. And I applaud, Steve Walsh's work and our nurses, SEIU, Senator Friedman. We've been working on this bill for a while. Like anything, it's a little bit more complicated behind the scenes, making sure that, who we're protecting, how we're protecting people, how we're tracking things, making sure that we're doing everything we can to kind of capture everything that we want to. And I think we're meeting again this week. I think we're very close to getting that finally accomplished, and I look forward to it. It's long overdue, and it's a great message for our healthcare workers. And I will just say, and I know, like Steve talked about this a little bit, like when you see the frustration of our hospital systems. 2 weeks ago, I went with a family member on a Saturday night, went to one of our major hospitals. And I sat in the emergency room for 4 hours while a family member was in a hallway. And just from watching 4 hours of how that emergency room operated, you could see the frustration. You got family there who has got a sick patient lying on a cot in the middle of the emergency room who's in pain, but there is nowhere to bring people. People are in the hallways, and you see the staff desperately trying to, manage not only the patient, but the family, and then trying to get that patient into a bed that is not available. Because of so many things we talked about, workforce downstream, because people in that hospital should not be there, but there is nowhere else for them to go, whether it's a skilled nursing facility or other nursing home or at home where they don't have the appropriate care set up. And at all bottlenecks at our hospitals, who then kind of have to deal with this and their staff, the frustration of a system. And you could see just over hours, the people coming out trying to console, the patient and then the family, and the frustration getting higher. And by the end, it's like, how would you want, no one wants to work in that environment. And the burnout, you just see it. You see it in their face, and they can't do anything more than they're doing, because there's no other option for them to get them into a room or move them out of that emergency room. So we've really got to fix these things, especially downstream, and you see how people can get really agitated. But again, we need to send a message to our healthcare workers, like going through a TSA agent, that you do not put your hands ever on a healthcare worker. So I think, though, to answer your question is, we are very close to having this done, and I think we should have it done very soon.
David Seltz alluded to a message of optimism. Bless you. In this situation, Senator, give us your most optimistic thoughts about what you think this session, which ends July 31st, I believe, at midnight, is going to get done, and also sort of maybe some broader thoughts about our system.
Oh, God. Well, I have a great partner, and I know that he cares as much as I do. I think if we ruled the world, it would look a lot different. I'm trying to be optimistic. I'm cynical by nature, but it's kind of, I think the only optimistic thing I can talk about is this is a problem that needs to be solved by everybody. And if everybody retrenches, goes back into their little space and protects their little corner of the universe, we will not succeed. If all of us say we can all put some real skin in the game, but if we work together, we can solve this problem, or we can make it better for so many people, then I think we really have a chance. And we have a lot, there's lots of headwinds coming at us. I think we need to look at this in a very holistic way. I've listened to a lot of what David said and what the panel was talking about, and you start to think like, pay for people's housing. If we don't have, we can't salary our way out of this. We can't just keep paying people more and more. What are all the things that we can do to support the healthcare system and the people in it so that they can do their jobs? And I know I'm not answering your optimistic question, but I guess what I'm saying to all of you is please, please, please be willing to sit at the table and give your share. We need to do that. Healthcare system needs to do that, and the patients need to do it as well, But that's what's going to get us out of this, and I just don't know any other way to do it.
Well, I think that was optimistic adjacent, but it's close. Turning to you, Representative. Final words, and in terms of where we're heading, what can we get done? What gives you hope?
Well, I do believe that we have, like the senator said, we have a lot of people who actually care. We have all different stakeholders that have a lot invested in it. We've got a system that really was set up and been built upon that we really need to break down a bit in this environment where we can do things much more efficiently. And I think some of those were spoken to earlier, especially with the administrative costs, the prior authorization, with people working at the top of their license we should be focusing on, but we need to do this across healthcare. And I do believe, like last session, we had the private equity issue that kind of sucked a lot of the life out of it. I know this, some of the federal cuts have now put us on our heels again as we're waiting to see what some of these challenges will be and how we're going to, plug some of these holes that are really significant. And that's what I think when the Senate says we're nibbling on the edges, we're trying to figure out how ways to save money, but we're looking at this enormous challenge. And that, like she said, is going to take everybody sitting together. We can't solve it. We need to come up with ideas. We need to figure out how we get through these for the next couple of years and keep our systems running. And as Steve said, we've got to think first about our patients, right? And how we can make sure that people here in Massachusetts have access to affordable health care. And that's going to be an enormous challenge, but we've got a chance to reset some things we're doing in healthcare, and I think we have to take advantage of those opportunities right now.
What a privilege to be with both of you. Please join me in thanking Representative Long, Senator Friedman. Thank you so much. Thank you, John. Thank you, Senator. Well, that concludes our program. Thanks again to Johnson & Johnson for sponsoring. Thank you all for being here this morning.